Hello, everyone. So this is TOG article from October 2021. Update on recurrent vulvovaginal candidiasis. This is vulvovaginal candidiasis is the second most common genital infection in women after bacterial vaginosis. 75% of the women will have at least one episode of vulvovaginal candidiasis in their lifetime. 6% developing recurrent disease. Recurrent vulvovaginal candidiasis is defined as 4 or more episodes per year. Two of these episodes should be confirmed by culture or microscopy. One must be by culture. Now, the most cases are caused by Candida albicans, 80 to 89%, and the remainder are caused by Candida species or yeast like Candida glabrata or Candida crus. Risk factor. Risk factor estrogen exposure. It can be puberty, pregnancy, HRT use, and hormonal contraception. Use of broad spectrum antibiotic within the last 3 months. Poorly controlled diabetes mellitus, local irritants such as perfumed soap, wet wipes, uh, fabric conditioner, and touches. Immunocompromised state. New sexual partner, spermicidal gel or cream. Non-compliance with antifungal therapy. Resistance to antifungal therapy. Iron deficiency anemia. Uh, Next is about how to do the diagnosis. For the diagnosis, we based on history, examination, investigation. History, we take the symptoms, duration, their severity, and exacerbating and relieving factor. Now, signs, the patients will complain of persistent vulval itch, non-offensive vaginal discharge, which is curdy or thin, soreness or burning, superficial dyspareunia, erythema, fissuring, swelling or edema, satellite lesions, and excoriation marks. Symptoms may be cyclical in nature. No. Differential diagnosis: eczema, dermatitis, lichen sclerosis, or planus, bacteriovaginosis, trichomonas vaginalis infection, aerobic vaginitis, cytolytic vaginosis, vulvodynia or vestibulodynia, vulval intraepithelial neoplasia, and vulval cancer. Bacteriovaginosis, diagnosis and management. Definition is it is an imbalance in the vaginal flora causing rise in the pH level to 4.5 to 6. There are fewer lactobacilli and an increase in anaerobic bacteria. Risk factors: smoking, dosing, black ethnicity, new sexual partner, concurrent sexually transmitted infections such as herpes, receptive cunnilingus. Signs and symptoms: offensive feces discharge, which is typically thin and white or gray, up to 50% asymptomatic. Investigations: we take a high vaginal swab, microscopy, pH testing using litmus paper. There are diagnostic criteria available to add the diagnosis, which is the Amsler or Hay-Eisen criteria. Management: metronidazole 400 mg orally twice a day for 5 to 7 days, or metronidazole 2 gram orally stat, or intravaginal metronidazole gel, which is 0.75% once daily for 5 days, or intravaginal clindamycin cream 2% once daily for 7 days. Alternatives are tinidazole 2 gram orally stat or clindamycin 300 mg orally twice a day for 7 days. Other informations are given. Vulval skin advice. Probiotics has been demonstrated to reduce recurrence rate. Next slide is about Trichomonas vaginalis. This is a sexually transmitted infection caused by flagellated protozoa, Trichomonas vaginalis. What are the risk factors? Are the older age, which is more than 24 years, non-white ethnicity, particularly Afro-Caribbean, concurrent chlamydia trachomatis, or Neisseria gonorrhoeae, people living with HIV too. Signs and symptoms are vaginal discharge, which can be malodorous, vulvovaginal itch, dysuria, vulvovaginitis, vulval ulceration, low abdominal pain. Up to 50% it can be asymptomatic. Investigations, vaginal swab taken from the posterior fornix, and preferably it is tested with NAAT, which is the nucleic acid amplification test. This is the gold standard. If not available, then weight microscopy is done. The management will be metronidazole 2 gram orally stat, or if it is because of side effects, then we can give 500 twice a day for 5 to 7 days. In this case, it is a sexually transmitted infection to make sure the partner is treated and both avoid sex until they have both completed treatment. Next is management. General measures: avoid local irritants, simple emollients, wash just once a day, avoid tight fitting garments, if possible, avoid pads or panty liner, avoid vaginal dosing. Now, the treatment for acute vulvovaginal candidiasis. Oral treatment is fluconazole 150 mg single dose. Topical treatment is clotrimazole pastry 500 mg per vagina single dose. For non-candida albicans and azole-resistant nystatin pastry, which is 100,000 per night for 12 to 14 days. For the recurrent vulvovaginal candidiasis, we do the induction and then the maintenance doses. For the induction, topical and oral. Oral is fluconazole 150 mg oral every 72 hours for 3 doses. For the maintenance, fluconazole 150 mg oral once per week for 6 months. For topical treatment, clotrimazole pastry 500 mg per vagina 7 to 14 days according to response. For maintenance, clotrimazole pastry 500 mg per vagina once per week for 6 months. For non-candida albicans, nystatin pastry per vagina 14 nights per month for 6 months. Treatment of vulvovaginal candidiasis in pregnancy and breastfeeding. Acute candidiasis, clotrimazole pastry 500 mg once a night for up to 7 consecutive nights. Recurrent vulvovaginal candidiasis induction and maintenance. Induction is the same clotrimazole pastry 500 mg once a night for 10 to 14 nights according to response. Maintenance will be clotrimazole pastry 500 mg per vagina once a week. It is important to remember that topical or intravaginal treatments can affect condoms and put women at a risk of unwanted pregnancy. Fluconazole and other azoles can react with other medication when given in multiple dose regimens, particularly in relation to their association with the hypokalemia and prolongation of QT interval. Clear medication history should be taken. If not responding to treatment, it is important to consider the testing for species other than Candida albicans or revisiting alternative diagnosis.